Get rid of the Q&A window. There we go. Right, so thank you for the opportunity to speak, and to Professor Forgo and his team for organising and running an excellent meeting, and thanks to all the attendees for hanging on to the bitter end for the final presentation of the day. So my name's Angela Bradshaw. I work at Alzheimer Europe as a project officer, and I am responsible for the work that we're doing, or partly responsible for the work that we're doing on the Virtual Brain Cloud project. I thought I would, apologies. There we go. I thought I would start my presentation by setting the scene for the project from a demographic perspective. So as you probably all know, dementia is a multifactorial, complex and chronic condition, which is characterized by progressive memory loss and cognitive impairment. Crucially, there is no currently available disease-modifying therapy. And in the EU, a report that we published last year indicated that there are currently almost 7.8 million people who are living with dementia. The cost of that was estimated in 2008 at over 160 billion euro. And of this rather vast sum of money, about 56% of that is estimated to come from the costs of informal care. So women remain disproportionately more affected by dementia than men, and there are almost double the number of women relative to the number of men with dementia. And this, we believe, is in part linked to the greater life expectancy for women. So you can see from the table to the right, table 6, from that report, that the prevalence rates increase dramatically from the age of 75 upwards. In more positive news, however, several recent studies, along with our survey, indicate that there's been a reduction in prevalence compared to what was thought would happen in 2008. And in fact, we had indicated then that around 9 million people would have dementia by 2018. So you can see that there is a reduction. And this is believed to be linked in part to improved management of lifestyle habits, such as smoking, and better treatment of conditions such as type 2 diabetes and hypertension, as well as improved diagnostic methodologies, and these three things combined have made us a little bit better at identifying people at risk of dementia, but also at potentially preventing dementia from developing or reducing the impact of dementia in the people who are living with this condition. However, despite the reduction in prevalence, the number of people with dementia is still set to double by 2050. At which point it will have increased to about 14.3 million people. So I mentioned just then that there are now established modifiable risk factors for dementia. There was a recent update to the 2017 Lancet Commission on Dementia Prevention and Care, and they estimated that about 40% of the cases of dementia worldwide may be due to modifiable risk factors, such as lifestyle habits and treatable diseases. So this really reinforces the importance of early diagnosis for dementia prevention. So, and this brings me on to the project. So Petra gave a fantastic introduction to the project and described how it is set up and what it's aiming to do. But essentially, just to reiterate, the objective of the Virtual Brain Cloud is to develop and validate a decision support system. And it will do so by providing access to high quality multidisciplinary data for clinical practice, resulting in a cloud-based brain simulation platform with the aim of supporting personalized diagnostics and treatments for people living with neurodegenerative conditions such as Alzheimer's disease and Parkinson's disease. So as shown in this schematic, the Virtual Brain Cloud project will use data from research participants with neurodegenerative conditions with the goal in turn of benefiting those individuals. So we are involved in the ethics activities for the project, and I thought I'd start at the beginning. So trying to establish what we mean by ethics in the context of research projects such as the Virtual Brain Cloud. So on a fundamental level, clinical research generally should be robust, it should be meaningful, it should be valuable, and it should ultimately provide society with accurate answers to questions that are worth asking. So how can we make sure that clinical research is ethical? So several ethical criteria for clinical research have been identified to ensure that, as I mentioned, research should be robust, meaningful, and valuable. And these requirements are closely related to the medical ethics principles that were first described by Bradshaw and Childress in 1979, the principles of autonomy, non-maleficence, justice, and beneficence. So autonomy being the capacity to make an informed decision, non-maleficence being about avoiding harm, justice being about the distribution of giving everyone what they are due, so fairness, and then beneficence being about balancing benefits so that they are greater than the risks and the costs of research. And in a 2000 publication, Ezekiel Emanuel and his colleagues laid out 7 fundamental ethical requirements for clinical research, which are listed here. And I won't read through the slide in the interest of time, but generally, they all speak to meeting those 4 fundamental medical ethics principles. So either at a level of providing social or scientific value using robust methods, so in a valid way, making sure that participants who bear the risk of participation should be able to enjoy the benefits. And this means that individuals who participate should be able to directly enjoy the benefits. It's not all about societal benefit. From a more organizational perspective, studies should be independently reviewed, and obviously informed consent plays a really important part in these ethical requirements. So that's respect for autonomy and personhood. And individuals have to be provided with the information required to decide whether or not to participate. And this actually has specific implications when it comes to people with neurodegenerative diseases or dementia, because it means that we need to ensure that we as researchers adapt our consent methodologies and mechanisms to enable them to participate in research. We also have to make sure that clinical research respects those subjects, and again, that the risk-benefit ratio is favourable. So the topic of this meeting was the GDPR, so I thought I'd put in a slide about ethics and the GDPR. I'm not a lawyer, I'm not an expert in data protection, but it seems to me that when it comes to data protection, or at least when it comes to patient privacy, data protection and ethics are somewhat linked. So I guess you could say that the GDPR applies a human rights-based approach to data protection. And actually, these rights are referenced in a few of the articles and recitals of the GDPR. Notably, Article 4 is listed here. So the processing of personal data should be designed to serve mankind, referencing the Charter of Human Rights and also the treaties, the foundational treaties of the EU, but also in Recital 33, illustrating the consent principle, and also importantly stating that ethical standards for research must be recognized and adhered to. And this really reinforces the fact that not all ethical principles are codified or depicted in the GDPR. So compliance with ethical requirements, as we all know, is pivotal to achieve real excellence in health research. And both the GDPR and also the EU and the funding bodies place a great deal of importance on ethics. So what does this mean in the context of the virtual brain cloud? So in creating the legal and ethical framework for the virtual brain cloud, we wanted to make sure that the people who bear the risks of research, in this case, the people whose data is being used to create these systems, are also those who will ultimately benefit from the research. And this is along in respect to the regulations and guidelines laid out in the Horizon 2020 manual for applicants, which says that there has to be a fair distribution of the benefits and burdens of research, and means that we need to perform a really balanced risk assessment about likely harm to the individual or his or her community versus our right to perform research for scientific or societal benefit on the other hand. So for those of you who are still around, I thought I'd put in a bit of live participation here. So if you have a phone, or if you're happy to do this on your computer or laptop, could you please go to www.menti.com, and when that window opens, pop in the code that you see there, and hopefully I should be able to. Here we go. Yeah, so I've switched the screen, right? So if you could answer that question in as few words as possible. So I'd like you to answer the question from the perspective, of an individual. So for an individual person at risk of dementia, what are the benefits and also what are the risks of AI in healthcare? And I'll leave this going for about a minute, and we'll see what this very expert and learned and intelligent audience comes up with. So you can submit multiple answers. So once you've submitted a few words, you can put more input in. Great. So here we have lack of explainability of the system, so that's a risk. Faster diagnosis, a diagnosis, which would be a benefit. Tailored solutions for specific patients, so personalized medicine. Improved and earlier diagnosis, balanced by the risk of false positives. Harm and stigma, yep. Constant monitoring, that's true. Having non-invasive tests is something that is of great value to people, especially older people who have often multiple comorbidities. But yes, over-reliance on AI outputs and under-reliance on human decisions is a risk. And actually, a good point, this may affect human knowledge and training in the future. So it's not just a risk when it comes to the individual who is being diagnosed with dementia via the AI system, it's also at risk to the system. So the healthcare training system and the healthcare system ultimately as a whole. Great. So thank you very much for your engagement. Oh, yeah, one last thing that's important. Knowing a potential decline earlier could be limiting life quality in the years before. So I guess that speaks to stigma. It speaks to the fact that dementia currently has no disease-modifying treatment. What are the real benefits of diagnosis when there's not a huge amount that you can do? So I'm just going to go back to the presentation now. There we go. So thank you very much for your engagement with that. So we took the approach of identifying the harms and the risks, or the ethical risks, in light of what we understand about what people with dementia would like to see in terms of benefit. So on one level, in the framework, we worked to identify general ethical risks for clinical research participants. So imagined on the one hand as ethical risks for the original participants who are contributing their data, but on another level as the eventual clinical research participants who might be testing and maybe even using the system as patients in a normal healthcare system. So some of these risks involved loss of privacy and confidentiality. We also felt that there are risks of physical and social harm as a result of participating in some of this research. So people may become fearful or distressed, particularly if they don't really fully grasp the implications of the research. And there may be problems also, there may be risks with inequity. So there may be unequal representation of a group of very heterogeneous individuals in research. On a second level, we identified some broader ethical risks of AI in healthcare. So very prominently, and something that was picked up by a number of you using the Menti system, the potential bias of the data chosen, the physical harms that might arise from erroneous decisions, so treating someone or not treating someone if they have been misdiagnosed. Loss of personhood was another risk, so seeing individuals as numbers, who also do we allocate responsibility to? So where an AI system is used to make a decision about healthcare, is there a different perception of who is responsible for making the ultimate decision? Is it the doctor? Is it the system? Is it a combination of both? And where does a person sitting in a clinician's office understand that responsibility to lie. And finally, there is also an issue with risk disclosure, potentially. So again, as I mentioned a few minutes ago, in the absence of disease-modifying treatment, what is the value? What is the benefit of risk disclosure? What can we provide? What is the benefit ultimately for risk disclosure for people who are at risk of developing dementia? And is it really justified from an ethical perspective? And based on these identified ethical risks, and this is an ongoing process, so this is a dynamic document that is still being shaped as the project progresses, we then identified some key ethical considerations for the project. So first of all, fairness and equity. So for example, we need to ensure that there's no bias in the data used to train the systems being developed. We need to ensure there's non-discrimination. This is also linked to bias. So people living with dementia or at risk of dementia have the right to be free from discrimination based on any grounds, including age, disability, gender, sexual orientation, health status. And then the two other principles or considerations, informed consent and privacy, are linked. So we need to respect their autonomy and personhood. So individuals should be provided with the information required to decide whether to participate or, in this case, contribute their data or not. And all measures possible have to be taken to ensure their privacy and confidentiality so that we can avoid discrimination and potential harms. And as I mentioned earlier, for people with dementia and other neurodegenerative diseases that are characterized by cognitive impairment, we've got to consider adapted measures for informed and ongoing consent, and whether the instruments for collecting this consent are really appropriate for specific groups. And going forwards, this framework will be further refined and adapted. So just to close off this presentation, I wanted to briefly introduce a topic that's closely related to ethics, the topic of public involvement, which is also known as patient and public involvement in some circles. So the strategic aims of Alzheimer Europe as an organisation are to provide a voice to people with dementia and their carers. We want to promote a rights-based approach to dementia, and we also want to support dementia research among those aims. So public involvement, or PPI, is fully aligned with these aims, as it's defined as the involvement of people with dementia in research. And it's part of a more global aim to make sure that research per se is ethically sound. And this is based on an argument that by involving end users in research and in determining the way in which the research is carried out and the important questions to address, we will be able to more accurately identify the harms of research, as well as be more effective at guaranteeing the benefits of research for individuals. So public involvement ensures that research is done with or by the public, not to, about, or for them. So it takes them from a passive role to a much more engaged and involved role. It means that people with dementia actively and meaningfully contribute to the whole process rather than being a passive participant. And it means that we have to create a real partnership between people with dementia, researchers, and other members of society that are involved in research. And ultimately, the goal of public involvement is to enhance the transparency, validity, and legitimacy of dementia research. So on this slide, I won't read them out in the interest of time, but you can see some quotes from people with dementia speaking about public involvement and why they want to get engaged in it. So Angela, who is from Austria and is living with dementia, says that she is not ashamed of her condition. She'd like to speak out about it. And she feels that she's in a much better position to tell you or tell researchers about her needs, her demands and wishes. Juan from Spain would like to do something constructive. Doing public involvement was completely new to me. Now I feel like I'm doing something useful, and I'm pleased to be contributing in this way. And finally, Geert is actually highlighting one of the issues that sometimes crops up when planning public involvement in research. So I would normally agree to take part in lots of studies, but some state that you need to have a study partner. And even if they don't, I would need support. It's a shame, but that's the way it is. So it really emphasizes how we need to take people's needs, individual needs, wants, and desires into account to meaningfully involve them in research. So each of the quotes on the previous slide came from members of our European Working Group of People with Dementia. And we founded, or Alzheimer Europe founded, the European Working Group in 2012. And it's coordinated by Diane Gove, who is involved also with the Virtual Brain Cloud, and Anna Diaz, who will be contributing to the work on public involvement in the project. So the working group is composed of up to 15 people with dementia, and each of these is nominated by a National Alzheimer's Association. We make sure that they're fully involved in all our work. So for example, the chair of the working group sits on our board. Prior to COVID, the group would have 3 to 4 face-to-face meetings a year. Now they happen virtually by Zoom, and they happen much more frequently because that's what works best for them and for meaningful input. And as I said, they're involved in all our work and also contribute to many projects in which we're a partner. And the pictures show how the working group has evolved from 2012 to 2017. And the picture in 2019 was at a session that they ran at our annual conference. So if you'd like to read more about public involvement generally, so in the public involvement work that Alzheimer Europe has been involved in, but also in the words of the people who are members of the European Working Group, here are a few of the publications that have recently addressed this topic. And as I mentioned, that we are looking to do some public involvement work as part of Virtual Brain Cloud. So we look forward to updating you on this work in the near future. So with that, I'd like to thank you for holding on to the end of this presentation. I'd like to thank all the organisers again for inviting me and for hosting such an interesting and engaging discussion. And I would also like to credit the other people who are working as part of Work Package 2 on the Virtual Brain Cloud, including the team at Vienna, led by Nikolaus, and at Alzheimer Europe, so our Executive Director, Jean, Diane, who's our Director of Projects and is our ethics expert, and I'm also doing some of the work. Thank you very much, and I'd be happy to take any questions.
Thank you, Angela, for your interactive presentation and the ethical input.